Okay, so welcome back. So before we proceed to the implant placement and everything, we'd like to show you a video on how this beautiful science of implantology has evolved over the ages. So here we go. Let's begin the video. I hope you'll enjoy it.
Implant dentistry evolution. To identify the present and see the future, we must look at the past. The history of implant dentistry is widely documented in literature. The purpose of this video is to highlight some transcendental aspects of this evolution from the 5th century BC to the 21st century after Christ. As Cervantes said in Don Quixote, "Pricier a tooth than a diamond." Today we might say, pricier an implant than a diamond. In the 5th century BC, Herodotus described the practice of medicine. In 2600, Hesi-Ra was recognized as the first dentist in the old Egyptian kingdom. The Code of Hammurabi in 1900 documented dental extraction procedures. Women of the court of ancient Egyptian dynasties received intraosseous implants of animal teeth and teeth carved in ivory. The first known sample of dental implant took place in the pre-Columbian era. Wilson Popenoe discovered in Honduras in 1931 a skull with an artificial tooth carved on a dark stone. Abdul Qasim, an Arab surgeon, described transplant techniques and produced them with bullock bones. Ambrosio Pare, a distinguished surgeon of the 16th century, highlighted the benefits of transplants. Dental transplants received the impulse of well-known individuals in the 18th century, such as Pierre Fauchard, the father of dentistry, and John Hunter, the father of dental transplants.
Around 7000 BC, with the Indus Valley civilization, we begin to see some of the first evidence for early dentists plying their trade. This comes in the form of holes drilled into teeth, presumably to remove decay. This drilling technology most likely came in the form of the bow drill, a fairly crude mechanical implement, but nonetheless effective. It is thought that bead making was the primary profession of these early dentists, who probably did house calls on the side. Though effective, this was likely far from a pleasant experience.
Meet Dr. Brennemark, who is the father of modern dental implantology. Born on 3rd of May 1929, a Swedish nationalist, an orthopedic surgeon, accidentally found out during his research work that a titanium rod which he had placed in the rabbit got integrated with the bone.
Okay. So let us move forward, thanking all those whom we saw in the video. So without whom, right now, implant dentistry would not have evolved. Huh? Yeah. Disco. Okay. So coming back to it, let us thank all those we saw in the video, without whom you and I wouldn't be practicing or learning implant dentistry. So let's pay a tribute to them and move forward. So let's come to the next aspect, that is the placement and loading. So as Dr. Chitram also said, and we also discussed earlier, there are two types of placement. Immediate placement. Immediate placement means you remove you remove a tooth or you extract a tooth, and at the same moment you place an implant. And second is the delayed placement. You wait for the bone to heal. You wait for the socket to heal. After 12 weeks, maybe, once the socket heals, you place an implant. That is called as a delayed placement. Now in immediate placement, again, there are two types of loading. What is loading? Now, loading means the second stage, you are putting the crown. So in immediate placement, again, you have placed the implant of the extraction and you are also loading it with a crown, functional crown. That is immediate loading. And what is delayed loading? Even though you have placed the implant after the immediately after the extraction, but you are loading it 3 to 4 months after the placement of the implant. That is the delayed loading in an immediate placement. Now we come to the delayed placement. What is delayed placement? Once you have extracted the tooth, you wait for the bone in the socket to heal for like say 4 to 6 weeks to 8 weeks. Once it is healed, you have good bone all around, then you place an implant. And in delayed placement, you place the implant and you load it immediately. That usually we do when we are using active implant. And then what is delayed loading? You place the implant after 3 months after the extraction, and then you load the implant 3 to 4 months after the placement of the implant. So that is the delayed loading. I hope everybody of you is clear with immediate placement, delayed placement. Again, immediate loading and delayed loading in either of them. If there are any questions, you can just put forward in the comment section and we'll get back to it after the end of the session. Some rules we practice and some rules I think everybody of you should also practice. Never speak to on the phone about the cost of the implant to the patient. So usually the patients have a very good habit or a bad habit, you can say, of asking various doctors. Many of you and most of the doctors use different systems. So the prices that they quote are different. So never speak about the cost. You can just tell the patient the cost depends on your condition. So once we evaluate you, we do your diagnosis, and once we see you clinically, that is when we can comment to you about the cost. And then the second most important point is give the plan what suits the patient, irrespective of what the patient wants. Sometimes the patient will come and say, I want teeth in 3 days, 4 days. Now these days there is a very something going on, teeth in 72 hours, teeth in 3 days. But the patient is not fit for that. If you see that is not possible to give, that might fail, just refuse. If you see the conditions are ideal for immediate placement, immediate loading, only then you commit to the patient. If you see you need to wait, you have to offer the patient what is good for the patient. Because if you come and get into the demands of the patients and you give him what he wants, he will come back with the whole processes a few months later and will tell you, what doctor, what have you done? So you just do what suits the patient, not what the patient wants. Follow a proper protocol, follow proper science, and follow proper rules. Then I think that is the base of having a very successful implant practice. Let's come to the two-staged implant procedure. Two-stage implant procedure. Stage one is the placement. Now in this slide, you see the edentulous bone on the top. You see there is a very thin edge and the length of the bone is good. So what you do is slightly with any drill or the starter drill, you just tabletop the crest so that you get a very good flat surface. Then you place the implant and you close the tissue, I mean suture the tissue. This is the placement. Precautions here. Always use a coolant. Do not forget to attach the normal saline to your physio dispenser. If you don't do that, and sometimes if the coolant is not going, if you're not, then it might result in overheating of the bone. That might cause a bone necrosis in future. And even if you have placed the implant very well and the bone is getting necrosed, it might lead to an implant failure. These days, there are drill which have internal irrigation system in them. So these are the best to use while this. So with the coolant and an internal irrigation, you will never have an issue of overheating or bone necrosis. Always give minimal trauma to harden the soft tissues. If the ridge is very much wide and you can see a good amount of bone, horizontal width of the bone, probably you can avoid opening of the flap. You can just use a punch technique. We will show the punch technique and the open technique later on in the hands-on. So by using the punch technique, you do not have to open the flap, do not have to give sutures. So the healing time is very less. It is very much painless and the patient might not even have any discomfort even after the placement of the implant. Knowledge of all anatomical landmarks, as we said, is very important before the placement. You should know where the nerve is, you should know where the canal is, you should know where the nasal fossa is, you should know where the bone, maxillary sinus is, and also the septum. Always enter the implant site with a static drill. Always exit the implant site with a moving drill. What do you mean by that? You just, when you attach your drill to the handpiece, you place it on the site in a static and then press the foot control. That is called a static drill. So you don't press the foot control and just start drilling it. You're not drilling into a granite, or you're not drilling into a wooden hole. You're drilling into a human bone. So make sure your drill is static before entering the bone, and always exit the implant site with a moving drill. So the drill is moving at 700 or 800 RPM. You exit in a moving motion. Sometimes what happens, if you just if your whole drill is inside the bone and you just stop the drill, stop the foot control, it might get just stuck and it might not come out. So always, while the drill is moving, at that point only you have to exit the bone. Now, another very important aspect is all threads of the implant should be covered by bone. Means, in other words, the implants should be completely submerged. Now, what happens if it is not? Immediately, the bucketing bone loss across the implant starts. So please be sure that your implant is always submerged inside the bone. Correction of angulation always with the next drill. Suppose your first pilot drill or the first drill that you use, if you feel that the angulation is not well, always check it with the parallel pin. And if you feel that the angulation is wrong or angulation needs some correction, second drill, you can position it slightly, the angulation that you desire, and then you can enter. You can always take the help of the twist drills for that, and always you can drill it properly to suit your angulation. Speed of the handpiece, speed of the drill should ideally be 800 to 1200, while in some cases of mandible anterior, as we spoke about in D1 type of bone, you can go up to 1200 RPM also. But the safest speed is 800 to 900 RPM. And in D3 type of bone, you can also drill with 700 RPM. Conditions required for the surgical success. Of course, total absence of infection. That is, now there are two types of, again, this thing. Here, you also have, we did not speak of those sterilization protocol. Everything should be completely sterile. Once you are gloved up for an implant surgery, the implant surgeon is not supposed to touch anywhere else. So once you're wearing your gloves, do not touch the light, adjust the light, or press the button of your chair or anything else. Once you're gloved up, you're gloved up. The only thing that you're going to touch is the handpiece and the patient's mouth. That's it. Then again, before starting the surgery, you have to use a betadine swab, clean the patient's mouth extraorally, and also if the patient, if he gargles with betadine, that should be good. So maintaining ideally, I would suggest everybody, if you are starting an implant practice, you should have a B-class autoclave to sterilize all your implant kits and all your implant instruments. So that would be absence of inspection from your side and absence of infection from the side of patient. So suppose if you are doing an implant in the lower first molar region, and the patient has a very bad deep cavity and some periodontal lesion in the adjacent tooth. So that is not an ideal scenario for the implant placement. You have to correct that. If you do that, if you do not correct that, the chances of implant failure are higher. Second thing, if the patient has a lot of periodontitis, he has a lot of calculus, he has bleeding gums, he has swollen gums, and then you put an implant in some area, the chances of success are very less. So first, correct the adjacent conditions. The tissue should be healthy around. Any pathology in the mouth should be corrected before you proceed for implant placement. Now we come to the primary stability. So the primary stability is once you start placing implants, you will come to the primary stability. Once your implant is completely in and you have the hand driver in the implant, you just try to move it and see if it is moving. Even if it is moving slightly, it is not primary stable. Primary stability means it should not be moving. Although even if there is space in the coronal region, but it is very much locked inside the apical region, the primary stability is good. Now, BIC is bone implant contact, the ratio, that there should be maximum contact between the implant and the bone. If the bone implant contact ratio is higher, the chances of integration and chances of success of the implant are much more higher. If the bone implant ratio is lesser, there are chances you might have to see the patient again and again and to correct many things. There should be adequate hard and soft tissue always around the implant. A healthy tissue around the implant means there should be good bone. The bone should be covered, the implant should be covered by a bone on all the sides. And if possible, you can place the implant little subcrestally. And then the soft tissue also should be very healthy and good around the implants, means on the crest. Peri-implant closure. Peri-implant closure means again the same thing. Once you put the implant and you close it with the cover screw or the healing abutment, when you suture the tissue, there should not be a gap left or anything. You can avoid this in a single in a single placement by the flap punch technique. But sometimes when you're suturing it up, you make sure that your sutures are good and you suture it properly. Absence of load around the implant. So I don't think this is of too much of a matter, but it means they usually when you have a single implant or a multiple implants, there will be partial edentulism. But if if the patient is going for an overdenture and he is an existing implant denture user, so you place the implant, you make sure the implant is very much subcrestal, and when the patient is using the partial denture or the complete denture which he has been using, that should not put excessive load on the fixture. Okay, so these are the very conditions required for surgical success. Any questions you have, you can put in the comment box and we'll get back to you in the answer session. Let's move ahead. Implant placement step 1. Now you can see on your screen there is bone, partial edentulous, there is a missing tooth. You can see the handpiece. The irrigation tube is attached to the handpiece, and there is the bone. The bone, you can see it's a round rod. This is the first drill. This is not used to, you are not supposed to just go and go maximum length. This is just the marking drill. With the round burr, you just have to mark the site of your implant placement. Got it? So when you start the foot control, just mark the site. This is the first drill. You're not, so the depth you have to go only 1 or 2 mm, the depth of that round burr. That's it. And just get out and change the drill. Step 2, you have to use the 2 mm twist drill. Now here, if you have sufficient bone and you're confident enough, then you can go full length, 8 mm, 10 mm, whatever is the implant size. And also it can be used to establish the final depth of the implant site. So if you're placing a 10.5 or 11 mm implant, there are markings on the drill. Even the Bioconcept drills, if you see, they are marked 7 mm, 8 mm, 10 mm, 12 mm, 15 mm. So, or you can see those markings and study those markings well. And when you are using the second drill, so you just first see the drill, calculate on up to which mark you have to go to the crestal one. And if you are using the punch technique, again, you calculate one step higher. So that will negate the length of the tissue. Go full length, stop it, and come once. Do not keep on drilling it again and again. That will again spoil your angulation and that will unnecessarily widen the osteotomy side. Once you are gone full length, just come out and get to the next drill. Before going to the next drill, in the drill, you will find something called as a paralleling pins. So here you can see you have to use this paralleling pin or the guide pin when you are doing a multiple osteotomy. Means you are placing 2 or more implants at the same time. When you do your first osteotomy full length, you can put those paralleling pin and see whether they are parallel, or you can check the angulation. While when you put the paralleling pin, you can also tell the patient to close his mouth a little bit, and the paralleling pin should point, the top of the paralleling pin should be pointing to the upper teeth, exactly perpendicular to it. If it is anywhere angulated, means somewhere you are mistaken on the angulation, and you can correct that angulation in the next drill. So that is the importance of paralleling pin. Initial days of your implant practice, I would personally recommend you keep using the paralleling pin whenever you're placing 2 to 5 implants or multiple implants, at least for the first 20 to 50 cases. use this technique. After that, maybe you will get good experience. Again, as I said, guide pin or the paralleling pin is the tool for checking the direction and position of the implant site to check the angulation and parallelism of the implant site. In case you are going wrong, you can always correct the angulation by the next drill. Now, step number 3. This is your pilot drill. Again, this facilitates the entry of the this. What will your pilot drill do? It will first expand the cortical bone, the crestal cortical bone. It will facilitate the drilling entry for the further drills. And the cutting portion, these are the sideways. The sides of this drill are the cutting portions, means it will start expanding the osteotome. Then comes the twist drill. This will be the final drill, 3 mm twist drill. Now we are talking about the 3 mm implant. So 3 mm twist drill or 3 mm drill, this drill will be the final drill for the 3 mm placement. This will drill up to the corresponding length markings that, as I earlier said, you mark the indicator where you want to, suppose you are placing a 10 mm implant and you see the marking on the drill, you have to go full length once and come out. If you are using a punch technique, you go 2 mm more and you have to come out. Ensure the parallelism. Now, there is something called as a countersink in the kit. This you can use to widen the implant site preparation at the crest. Crest means the coronal position, or just below the level of the bone. This is not mandatory. You can skip this drill. And why sequential drilling? See, right now the drilling process that I explained, sequential drilling will, the resistance of the bone will get to know, and this will not, if you're jumping the drill sequence, it will start wobbling of the drills. The direction and the orientation of the implant might change. Okay, so you have to use the proper protocol which is there in the kit. And we will show you the Bioconcept BB and the BC system kit later on, and they have a wide range of drill. So while we do the hands-on, we'll come to it later on. Now, once your complete osteotomy is done, the implant placement is the next step. Then now you can place the implant by 2 ways, either by means of hand placement or by the motor placement. So in the kit also you will find the hand driver as well as the motor driver. So you attach the motor driver to the implant handpiece and make sure you change the mode of your physio dispense. For beginners, this is very important because right now your mode is at a rotation mode at 800 or 1000 RPM. You put this and you apply the implant without changing the mode. You will just zoom, drill it deep inside the bone, and it will never come out again. So at every point of time, whenever you are placing the drill in the patient's mouth, just have a look at the physio dispenser and see what mode are you at. Whenever you are holding the implant in the motor, just make sure you always look at the physio dispenser mode. The torque of the placement should be at least around 30 to 40 to ensure good primary stability. Okay, so typically, now you can see this implant placement certificate fixture comes in variety of lengths that we discussed. Typically, wider the better. So if 4 mm, 4 to 5 mm is the most ideal placement, 4 mm or the 4.5 implants are most ideal. If you are getting lower, like if the bone does not permit a wider implant, then you should compensate it by a deeper implant to maintain the bone implant contact ratio. Now, screw implants can be placed by hand ratchet or the motor that we already discussed. Once the fixture is placed inside the bone, the second step will be the implant packet. The implant box comes with the cover screw. You just unfasten the cover screw and you make sure you put it inside and cover this implant. And make sure when you pick up with your X driver, just make sure you put your hand below and take slowly near the patient's mouth and just screw it in and then suture it up. Because sometimes what happens is even the slightest of movements of the cover screw falls on the ground. Then again, you'll have to open a new cover screw because you cannot put the cover screw which has fallen down. So cover screw is basically something that is used to cover the open surface of the implant. In some cases, you can also use the gingival collar or the healing abutment when you are very much sure. Let's go to this video. This is the extraction, the healing. After the bone is completely healed, you can see the good bone. Here we place the implant, and that's your implant with the crown. So this is what the placement is look like, and you have to maintain this. You can see these dimensions at least 1 to 2 mm from the adjacent teeth, and there should be a minimum distance of 7 to 8 mm between the adjacent teeth when you're placing an implant. Let's go to the technique. Here we give an incision. Incision should be more towards the palatal side or the lingual side so that the suture in the covering becomes easier. This is the first round burr, just to mark the site and to tabletop. So once you have done the tabletop, you just mark the side of your implant. You can see the drilling process and you can see the irrigation. So this is an external irrigation. Now, these days there are drills with internal irrigation too. This is the twist drill. You can see the markings on the twist drill and the revolutions. Now you have gone to the depth. This is the countersink. Okay. Paralleling pin ensures the parallelism of the implant of the osteotomy site. Okay, remove the paralleling pin. Now go with the 2 mm twist drill with the 800 to 1000 revolutions per minute. Make sure you're using the coolant. Coolant is going properly inside to avoid overheating and necrosis. This is again the paralleling pin with the markings. You can see it's gone full length. You can confirm this by means of a radiograph or an RBG. Then you go to your final drill slowly. So you enter statically and you are exiting in a moving motion. Again, you put the paralleling pin and check this depth. This should be your final drill and maybe at a lesser RPM. Again, make sure the coolant is in place. Check it with the paralleling pin. This is the countersink. You can avoid this. The countersink is only used to widen the area at the crest. And here you go. Your implant is slowly and steadily moving inside the bone. You can see the implant, it's subcrestally placed. All the threads of the implant are completely inside the bone. And that's the implant in place. So we will show you the complete process, the drilling sequence and everything while we do the hands-on. This is the ratchet to remove the connection. Loosen it up. You can see the implant, the hex, and now you put the cover screw. Cover screw is in place, and then you just, if needed, you can do some bone grafting. In this case, there was some deficient bone, so the animation is showing some bone grafting. Cover it with a membrane, either a collagen membrane or a titanium mesh, and here your sutures are in place. Looks easy, right? We'll make it easier for you while we do the hands-on. Now come to the case discussion. Now you can see here there is a missing first molar in the mandible. You can see the bone, there is a little bit of a bucketing bone loss, maybe because the extraction was done quite a few years before. Clear? The first molar is missing. This is a photograph from the photographic mirror. Here we plan. Now in occlusion here, there is enough inter-arch space. So we have a good space for the crown. So we can go ahead with an implant placement. Confirm it with the radiograph, see the crest of the bone, see the alveolar canal, alveolar nerve. There is enough space. You can measure the space. If you have a simplicity, you can measure it. Even nowadays with the OPGs, you can have a measuring tool. Confirm it with the OPG. Here you can see the mandibular canal is easily visible. You can see the crest of the bone, the good size between the adjacent tooth, and a good inter-arch distance. So vertical distance is also good for the crown. So here we plan your surgery. Moreover, if you want to go for more diagnosis, you can go for the CT scan. say CBCT, I mean. The CBCT shows good amount of bone, a good cortical bone, both side, a buccal bone, stable lingual bone, good ridge, the width of the ridge. This is the panoramic view of the CBCT. You can see a good trabecular pattern in the bone. This should be a D3 type of bone, as we can see in the radiograph. This is the cross-sectional view. You can see the slide number 26, 27, 28, 29, and 30. So slide number 25 to slide number 29. This is the area for placement. You can see good bone, good width, good height. This is making it more clear. Very good. So here the crest of the bone is not pointed, so you did not have to tabletop the bone. So here 4.6 mm is the clear width and 17.8 mm. So here the readings are in centimeter, but we usually use it in mm. So 4.6 mm is the crestal width and 17.8 mm is the length from the mandibular canal. Again, correct. So now the implant size that we select is a 4.3 diameter and the length is 30 mm because we had a 17 mm depth. Okay, so now we'll come to the stent and the guided part of the surgery. There is something called as a guided surgery. I'll give it over to Dr. Chitrang to take it over from here and see you in a short while. Over to you, Dr. Chitrang.
Yeah, hi, welcome back. Hope all things are clear up till now. We all had a small break to energize ourselves. And this is the most important part for dentists who don't have all the access to technology, who don't have all the access to patients who cannot travel too many times to their office because they are very old or they are living far, or you don't have the support that you need in your area of practice. And that is why this fabrication of surgical stent for a beginner, especially, is very important, though I still do for many cases even today. And it's a very easy task because it's not something that you need a lot of lab support for. You can actually do it yourself. You can teach one of your clinic staff also to do it, and you can overview the work. And it's not that of a task to complete this diagnostic cast. So we always take an impression whenever we have our patient in our office who is even looking for the discussion for implant, and we have briefed them that what are the do's and don'ts and what is the advantage over a bridge. And if they do agree, then we always immediately take a diagnostic cast in the first appointment. And this is what we do. What we do is we all have these denture teeth in our drawers, and depending on the tooth that is missing, you select one, you put some wax, stabilize it over there, and put some cold cure and ensure that you have created a small single tooth PD or sometimes even two teeth PD, which takes support of the adjacent occlusal surfaces like a jig. And whenever you have your patient in your office for the fixture placement, that is when you reflect the flap, you place this diagnostic cast with a stent, which has a small hole in the center. Now, why is this key? One, you have already established what is the center that you want in the horizontal space, and is also, if you are somebody who likes to have an access hole during your processes, which I love. Most of my processes, unless they are having a labial, the screw hole has a labial exit. All my processes are always and always with a screw access hole, which ensures that I have retrievability towards my processes if the patient needs anytime in future. Now, this can be created by a simple carbide burr or an erotor burr, and should not be more wide than 2 millimeters, which is the size of your pilot drill, or the lance drill is what we call in today's prosthetic kits. So this is how what Dr. Rikin has already briefed about the same case. We have placed an incision, we reflect the flap, periosteum completely, ensure that there is no tear, we respect the soft tissue and the hard tissue. If the floor of the mouth is very high, then you can sometimes take the suture for the lingual tissue so that it does not keep on coming in way of your drilling protocol, and that way you can ensure that there isn't any tear on the mucosa. Irrigation, again, you have two ways. This is a straight handpiece just to mark the center of the osteotomy, and that is why we have the external irrigation. But we have implant motors which support internal irrigation, external irrigation on the handpiece as well in today's world. So that is always a possibility. This is a stent in place with the marked hole in center. You use the handpiece, make the center hole. Now you have that dish marking, which ensures that from here on, if you have visualized this implant multiple times, three-dimensionally, you know which way to drill. Your angulations can be maintained, and you can always take support of the guiding pins like this. Take X-rays. It's no harm to take multiple X-rays in your initial practice days when you're practicing implantology, because we don't want to go wrong. We don't want to damage the adjacent tissue. We don't want to violate the anatomical landmarks. And it's not that we are always aware of everything. So ensure that we document whatever we are doing. So as an initial practitioner, you are ensuring that these are the steps that I have followed in placing the implant, and there is nothing wrong that has been done, even if sometimes the implant does not work the way we had expected it to be. But you always should have your due diligent procedure in documentation. That's why a guided pin with an X-ray is always very important. You then start with your lance drill, then the twist drill sequence. As mentioned again, you start with a static drill, but when you enter the osteotomy, but when you exit, it should always be in the rotating motion. Use the stoppers if you have. BV kit is wonderful. What we have after the initial lance drill is all the drills have the sizes of the fixtures that are corresponding to it. So we have an 8.5 drill, we have a 10 drill, we have an 11.5 drill, and we have a 13 drill. So this is an exhaustive kit, but what it does is that if you have done your planning well and you know that your implant size cannot exceed a certain amount of depth or height, then you can use a diameter and a length of the drill which is a size smaller and correct it at the final stage, or you can directly start with the drill size that you want to go with. So that is why the stoppers are equally important, because in the lower mandible, a lot of times you come across a very cortical dense bone initially to drill. So you feel that there is a lot of resistance. The speed is high, and then there is sudden drop because of the soft cancellous bone. And we don't want that. We end up either perforating the lingual cortex because of a wrong angulation, or we have damaged the nerve. And that is why the stoppers are very important when we are using our implant fixture osteotomy. This is how the implant comes. BV has a different packing. They come in a vial, and they have the implant carrier. You can either use implant motor to carry the implant fixture into the osteotomy, or you can even use a hand ratchet. This is how it has been, placed into the osteotomy. We have the implant fixture into the bone. It's the cover screw going in. Sutures placed. Uh, we want a tight closure, but we don't want too much pressure on the mucosa as well. We don't want excessive blanching. If there is some, it should relieve by a few minutes after the suture is taken away. Couple of sutures should do the trick. This is the implant in position. This is how axially we have planned or visualized how it should be, and that is how we would like to ensure. This is now after a phase of 2 months or 4 months, depending upon your osteotomy and your experience with the implant stability when you have placed the implant, or the medical conditions, or sometimes you have patients who are not staying locally, who come, like we in India have a lot of non-resident Indians who stay abroad and come yearly or annually to their hometown. That is when we do the second surgery, which can sometimes be as long as 6 months or even 1 year. But that's not the case. That's not more the merrier is what I always tell my patients. Minimum is what we need is 8 weeks for the mandible and about 10 to 12 weeks for the maxilla. So second stage surgery, if you have a good thick mucosa, the best is to take the incision, reflect the periosteum. Sometimes you can see this small metal shadow through the bone. If you have good bone healing, the bone a lot of times covers the cover screw, and that is when you have to be very careful. When you are trying to remove the bone, you should not destroy the hex of the cover screw, because otherwise it does not become retrievable. This is how the implants look after they have been uncovered. These are old external hex implant concept. These are the impression comfort copings, what we call comfort caps, which are allow the mucosa to heal around the implants. So we have a wonderful soft tissue which ensures that the mucosa gives an ideal environment for the prosthetic caps. These are the caps in situ. Again, you can see two small black holes, which are the access holes for your screw retrieval. This is very important, especially in posteriors, because a lot of times when we do a case, what happens is sometimes in this case itself, imagine a patient is losing the immediate next tooth due to a root fracture or a crown fracture. Then additional implant ensures that you just have to remove the old prosthesis from your previous implant and maybe make a bridge of 4 units or 5 units by adding only one fixture. This makes your job easier and also ensures that if there is some issue with the patient for prosthesis or healing or hygiene maintenance, you can always remove and send it to the lab for any repairs. These are the other few surgical procedures, which we generally happen to do in today's world, and that is because you have mastered your basic implantology. You know you have done enough of number of implants, and you are okay to go to the next level. And what is the next level? That is what we call GBR. GBR is nothing but guided bone regeneration. Sometimes we have horizontal defects, we have vertical defects. We have seen the maxilla where the sinus has the restrictions because of pneumatization. It reduces the residual bone height that is available in the posterior maxilla, and we have to do some sinus lifting procedure. Nasal augmentation is one area where we sometimes, it's most rarely done, but a lot of times some dentists prefer that. And the inferior alveolar nerve repositioning. Now, this is one thing that we should leave it to the masters. Even if you know your implantology well, you should leave it to the trained surgeon who will ensure that he will do the needful for you for the alveolar nerve repositioning. So success and survival of implants. Now, what do we mean by this? These are the stable parameters after functional loading, healthy soft and hard tissue levels, and good tissue response of the adjacent teeth. Now, why this is important? One is called the successful implant. That is, you have placed an implant fixture, it has healed, it has shown good primary stability, and you are good to load it for the second stage. But it does not always mean that it is fully functional. The tooth that you have given is not having an ideal load, or it is having areas which are difficult to maintain hygiene and is causing either dental issues with the adjacent teeth, or the neighborhood teeth are getting damaged because of that. So we have to see success and survival as two different things. Success is one of your surgical part where your implant is healed and integrated. Survival of implant means that the fixture and the processes are giving their due diligent prosthetic function for long term without causing damage to your adjacent tissues, and that is utmost important. That is where again the pre-evaluation and planning comes into importance, because all these things, if looked into before start of the case, you don't have any surprises which unfold later. So that's why we always say it takes less time to do a thing right than it does to explain why you did it wrong. And that is the reason we all have been emphasizing time and again that we should plan, plan, and plan. and only then come to the restore function part, and that is placing the implant, allowing it to integrate, and then going for the prosthetic phase. So what are the implant laws? Just a little bit on the funny side. Implants are unpredictable. Why? Because patients with good bone have no money and patients with money have no bone. It's very common in our practice. We see it very often that we have patients who say, Doctor, I'm fed up of this denture. Please do something. And we have a look, take all the money that you want, but give me fixed teeth. And when we look into the jaw bone and there is nothing, it's all atrophic mandible or maxilla. Either you have to do a lot of bone regeneration or implants are absolutely not possible. Learn to say no. This is very important. Why? Because you will always be tempted to, if a patient is saying, yes, I'm ready for implant, but are you ready? Are you good enough to give the 100% to your patient? And that is when you have to learn to say no many times. And there is no harm in it. If the patient is also medically compromised, but is very keen on getting an implant, but you know that it's not good for them, then it's better to say no and go for alternative treatments. Always remember the cost is long forgotten, but the quality is remembered. Why is this important? Because if you have done your proper evaluation, planning, and execution, then even if you have charged X amount today, it will be forgotten because the service of your treatment will be what will be remembered. If you place an implant and it is functioning well, and the patient is chewing everything that he would wish for, he or her, then they are going to remember you and even share your goodwill to their other relatives and patients. So as we have been speaking about the implant fixtures and their components, this is the BV dental implant system that we have been introduced in the month of January. And since then, we have used quite a few implants from the Bioconcept BV system. And believe us that they have been wonderful and they are as good as any reputed implants that you would have used in your practice earlier. Or even if you want to start with doing implants, then using BV dental implant system is something that I wouldn't say is a wrong choice. It is a perfect choice because we have all the prosthetic requirements that are there to offer. Also, the kit is, as mentioned, very elaborate with all the components involved, the lance drill, the side cut drill. We have the 2-0 twist drill with all the sizes as per your implant fixture size, as I had mentioned. And it is always safe to use an 8.5 if you know in the mandible you don't have enough height that and you always want to be at least 1.5 millimeters or 2 millimeters from the inferior alveolar canal, because what we can see as a radiographic shadow or on the CBCT, you always want to mark a safe distance of 2 millimeters before you start your osteotomy. We have all the 3.5, 4.0, 4.5 fixture drills, which are of various sizes. We have the mount drivers, we have fixture drivers. This is your ratchet, this is your depth gauge, parallel pins, everything that you would want in a kit is what we have in the Bioconcept. Lance drill to be used at 1500 RPM. That is your initial drill. It helps you take the initial cut into the bone, and since it is sharp tip and side cutting, it ensures that the cortical bone is easily cut, and it helps you engage the bone for your future drills. This is how it is. It's a little triangular in shape with depth markings. The first marking is of 7 mm, second is 8.5. The band that you can see, the lower border is 10 mm and the upper border is 11.5. That is how most implant systems are designed. The side cut drill. Now, side cut drill is a very least used drills for a lot of dentists, but we prefer that very useful drill, which is used a lot of times when we do immediate implant placement. You have extracted a premolar or an upper anterior or even a lower anterior, and you want to correct the angulation, because the angulation of the root is not the angulation of the implant that you want to place in the bone. If you see your lower anteriors are placed with the apical end lingually and the coronal structure angulated labially, but you don't want to place an implant like this because there is a risk of perforing the lingual cortex. You want to place an implant either straight or a little lingual to buccal because you have ample bone in the symphysis area. So this side cut drill a lot of times helps us change the course correction or also allows us to cut the bone on sideways. This is how it is. It has flutes at the sides and it helps in this fashion. Drill extension can be used when you have uh, areas where suppose you have a first molar, but the second molar is missing, either in the upper arch or the lower arch, and the bone has resolved. There is a bucketing over there, and you have to try and access that area. Now, if you have used your regular size drills, then the first molar will block your depth entry, and that is why you need a drill extension to ensure that your drill goes up to the desired depth. This is how it helps. It has a latch in which your drill will get engaged, and you have to use in the similar fashion. These are your pilot drills to be used as per the length that you would want to make the osteotomy for. And these are your taper drills starting from 3.5 because the first fixture is which is from 3.570 length, and you have the subsequent fixture sizes and the drills based on your planning evaluation. You will start with the same drill or you will start sometimes a drill lesser so that there is a scope for post course correction, because once the implant is opened, then it cannot be placed back and used for another patient. So if you always be sure that your osteotomy is not over prepared. Under prepare is fine because you can always correct it, but over preparing will have you will, and if you have opened the implant fixture, then you will have to you lose it and use an additional one, open a new one, and that is always a cost to the dentist and not to the patient. So be careful when you are doing your osteotomy. There is no hurry. Take your time. The anesthesia is doing its job, and you have to ensure that you do yours as well. So these are the taper drill parameters. That tip is of 1 millimeter, and the coronal section again is of the 1 millimeter length. The rest is your active drill, various diameters. RPM depends on your expertise as well as understanding of the bone. If you have met with a lot of resistance or you are in mandible and you have seen in the X-ray that it's a D1, D2 combination, then ensure that your drill is working at 1,000 to 1,200 RPM, but you have a coolant always to ensure there is no overheating. I prefer to put my normal saline or the coolant in refrigerator before starting because that ensures a further cooling of the bone when it is drilled. Cortical drill are basically to expand the coronal part. If you are experiencing too much resistance at the coronal structure, which is the cortical component of the bone, then it is advised to use that drill initially so that when your uh, drills are used, they don't meet with a lot of resistance. It reduces the wobbling and it also ensures that you can reach the proper depth. And what is more important is this drill also will ensure that your coronal part of your osteotomy preparation is not violated because the twist drill is taking too much time to cut. If the cortical drill has been used, it will cut in a very smooth and definite way to ensure that there is no damage to that cortical edge, which is very important after implant placement. That is the bone which we end up losing a lot of times because of overheating or because of surgical violation. So it is very important to use this. Parallel pins are of utmost importance for beginners. Will show some X-rays in which the importance of parallel pin is very much emphasized. It helps you ensure your spatial position of your implant in the bone as well as per your planning. X-rays can help establish and confirm whether your entry into the bone is as per your plan. This is how what Dr. Rikin was saying, that when you ask the patient to bite, the parallel pin should just slightly oppose the opposing arch in a manner in which it is showing that it is parallel as well as within the arch form and not too buccal or too lingual, ensuring that the occlusal loads are along the vertical axis of the implant fixture. This avoids implant failures, implant collar fractures, or abutment loosening. Drivers again used to put up the hex screw or the prosthetic components. We have the short and the long. These are the torque drivers. Again, we have the short and the long option in that. This helps in tightening the abutment to the fixture. Mount drivers. This is for you to carry the implant fixture from the packaging into the osteotomy site. This is how it is done. You can see how well it has fit into this thing. Always ensure that you are carrying your implant fixture in this particular manner. It is very important. It should not be facing down, because a lot of times we feel that the mount has engaged with the implant carrier, but it's not perfectly engaged, and it can fall down. And then again, as I said, if it's down, it's yours to pay for and not for the patient. So always be sure the moment you have engaged, ensure that it is facing upwards. Take it to the osteotomy. Ensure there is no contamination with the tongue, with the saliva. You have good suction in place, good retraction of all the tissues. You don't want soft tissue to get entrapped between the fixture and the osteotomy. These are the ratchet torque wrench with the torque drivers. You can manually pick it up, place it in the osteotomy area. These are the fixture drivers which help you torque your fixture to the desired depth and torque with your help of torque wrench. Always take care of your torque wrench post surgery as well. Clean it well, oil it, remove the excess oil before putting it into next level cycle of sterilization. These are your depth gauge. Few other components. This is how they have shown the drill protocol for a 3.5 drilling procedure. You take the lance drill, the twist drill, check your parallel pin for your angulation. Again, reconfirm the depth gauge. Use the twist drill at the desired speed in the cancellous bone. Again, a combination of 3.5 direct and cortical drill to have the final osteotomy and the fixture. So as we had said that the BV system of Bioconcept is compatible to all the Korean and mainly the Ostem TS3 variant, which is all 100% identical. All your components fit well into each other, and I have used the BV implants and they are just wonderful. I have loaded a few also in the last few months, and we will see if I have them accessible to show the before and after. So this is all about the BV system that